Well, thank you, Juggin. It's really a pleasure to participate in this important meeting, always the state-of-the-art new thoughts and evolution. These are my disclosures, and relevant to this talk, we've been an investigating site for the medicines company with Inclisaran and involved in 4 of the trials with Regeneron's ANGPTL3 protein inhibitor. So I've been a high enroller for these studies and have some insights, perspectives that I'd like to share with you. First of all, I think it's important to understand residual cardiovascular risk. We all want to do the right things for our patients and think that following evidence-based therapies may be sufficient to lower the burden of cardiovascular disease to the same as somebody who doesn't have a prior cardiovascular event, but that's actually not correct. I'll show you that data. I'll then move on to discuss the genetics of PCSK9, therapeutic approaches for modifying PCSK9, and then move on to ANGPTL3 protein, which is probably a new target that you may be far less familiar with. In patients who have a myocardial infarction who undergo PCI, who are on prescribed antiplatelet therapy, beta blocker, ACE and ARB, and high-intensity statins, we had the opportunity to evaluate cardiovascular risk. In this analysis of the Medicare beneficiaries, individuals who had these events on optimal medical therapy have a 8.54-fold higher risk of a recurrent myocardial infarction than age and sex-matched controls. They're more likely to end up in the hospital by 7.82-fold, and have a higher mortality rate. These events, despite optimal medical therapy, are even higher than patients with diabetes and patients with coronary disease who haven't had a myocardial infarction. So if you think that you're doing all you can for your patient, look at this data and find out that there is more to do, that the targets that have been established for lowering cardiovascular risk may not be sufficient to reduce the burden of cardiovascular disease in this very high-risk population. Now, if we evaluate individuals who have a myocardial infarction and look at some of the risk enhancers, if you have prior diagnosis of coronary disease before your MI, your risk of having a recurrent MI is increased 2-fold. If you have diabetes and MI, your risk of having a recurrent MI is increased 2-fold. Similar for chronic kidney disease and heart failure. Mortality is also increased in these individuals, and if you have heart failure before your MI, your likelihood of dying is increased 2.67-fold. So this idea of a high risk and a very high risk population is very important when we encounter all of our patients and guide them through the process of secondary prevention and discuss with them the need to be aggressive and, importantly, for them to be adherent to our treatment approaches. So I'd want to reiterate, as the guidelines stated emphatically, that statins are first-line therapy. High-intensity statins for people with atherosclerotic cardiovascular disease, but sometimes high-intensity statins may not be well tolerated or may be insufficient for lowering the LDL cholesterol to a minimal acceptable target less than 70 milligram per deciliter and perhaps less than 55 milligram per deciliter, in line with one of our publications in 2018 in JACC, and in line with the recent European Society of Cardiology guidelines. You engage the patient in a discussion. You let them know why you're doing what you're doing, where you're going, but also discuss potential for adverse events. It's very important for the patient to communicate with you and not just drop out of the care until they have a recurrent myocardial infarction. Let's talk about genetics. The ERIC investigators, Jonathan Cohn and Helen Hobbs, were pioneers in this area. They identified loss-of-function mutations in PCSK9, which means that PCSK9 levels are lower and the effects of PCSK9 on degrading the LDL receptor is impaired. There are different traits in African Americans than there are in white Americans. The traits in African Americans are associated with a lower risk of myocardial infarction than those in white individuals. we had the opportunity to expand this data, an analysis of the CHARGE consortium that included ERIC and many other prospective population studies. In this study of whites, there was a 13 milligram per deciliter lower LDL cholesterol with loss of function variants and a 18% lower risk of coronary heart disease events. However, in African Americans, the mutations were associated with a 35 milligram per deciliter lower LDL cholesterol and a 49% lower risk of coronary heart disease events. So what this is saying is that genetic mutations in which the PCSK9 levels are reduced the most are associated with a lower risk of coronary heart disease events. And this served as a basis for the pharmacotherapy that we now have available to us. Now, what is PCSK9? It's a mouthful. Proprotein convertase subtilisin connexin 9. PCSK9. What is PCSK9? It's a protein that circulates in the bloodstream, that binds to the LDL particle, and when it's bound to the LDL receptor, it serves as a death signal for the LDL receptor. So PCSK9 binds to the LDL particle, gets internalized, that particle is taken up by the lysosomes where it gets degraded. Because in the normal situation, the LDL receptor recirculates to the surface of the liver and binds more and more LDL particles. So just think about it as a death signal. So we would want to inhibit the activity of PCSK9 by either binding it by an antibody or inhibiting its production. And these are the approaches that are available to inhibit PCSK9. The one therapy that has failed is humanized antibodies to PCSK9 because bocociximab, the Pfizer compound, resulted in autoantibodies that diminished the effects of that therapy on LDL cholesterol levels. But we're going to review all the data as a segue to the small interfering mRNA approach. Now, the human monoclonal antibody approach results in binding of the PCSK9. And because you're binding the PCSK9, the levels of the PCSK9 in the circulation actually increase. But at the level of the plaque, the action of the PCSK9 diminishes. And we know from the Galegoff study, as one example, that one can decrease the cholesterol in the plaque, decrease the lipid core in the plaque, and get net regression. The small interfering RNA, however, decrease the production of the PCSK9, resulting in lower levels of PCSK9 in the circulation and lower PCSK9 levels in the plaque. So they're both targeting PCSK9, but the difference is the PCSK9 level and what that may or may not mean for inflammation and potential risk of diabetes. This is a summary of the 3 outcome studies with the monoclonal antibodies that we published recently in Circulation Research. And most notably, the Fourier and the Odyssey outcome study are using agents that are available on the market, evolocumab or Repatha, alirocumab or Praluent. As I mentioned, bocociximab was evaluated, but is not being developed because of the autoantibodies. The population in average in these studies was about 60 years of age. Myocardial infarction was present in about 80% of Fourier and Odyssey outcome study. Many patients had diabetes, as shown here, and other major risk factors. But again, I want to just move on to the major results, is that all 3 trials showed a reduction in the primary endpoint of cardiovascular events with or without hospitalization for unstable angina. And over 2.2 years in Fourier, 15% reduction in events. Similarly, in SPIRE 1 and 2, 12%. And in Odyssey outcomes, 15%. Hard endpoints were reduced by 20%. in the Fourier trials. So all 3 trials showed benefit, large numbers of individuals. But the request was to focus on Inclisaran, and Inclisaran is being evaluated in the Orion Clinical Development Program. And we've participated in Orion 1 and Orion 3, which is a open label extension trial. But there are many studies looking at LDL cholesterol lowering effects and effects on other lipids and lipoproteins, and I'll just go over that data briefly. This is the Orion study. It's a dose-ranging study, and the regimens that were evaluated included once dose starting regimen of Inclisaran, 200 to 500 milligram, and then a 2-dose starting regimen separated by 90 days. In other words, you get 1 dose, get a 2nd dose at 90 days, and then every 6 months. In this population, people again were in their early 60-year range. The LDL cholesterol was averaging about 128 to 130 milligram per deciliter. The lipoprotein A levels were about the 90, were not elevated in this study, but tended to be higher in the 2-dosing regimen. The reduction in LDL cholesterol was seen with the 300 milligram per deciliter greater than 200 to 100 milligram per deciliter. Looking at this dose here at the 6-month time point, a 51% reduction in LDL cholesterol. And the important thing is that this therapy is given every 6 months, in contrast to the human monoclonal antibodies, which are administered every 2 weeks, or with the Pushtronic device, or high-dose alirocumab once monthly. So patient convenience, I think, is an important aspect of this treatment. As I mentioned before, PCSK9 levels fall if you inhibit the production of the protein by interfering with the message to the DNA. Other lipoproteins that are reduced most notably include the non-HDL cholesterol, apolipoprotein B, the major protein on atherogenic lipoproteins, as well as lipoprotein A, and interestingly, a reduction in C-reactive protein. Now, the reason I make that comment is that PCSK9 is pro-inflammatory, and Inclisaran, unlike the human monoclonal antibodies, reduces the level of PCSK9. So there may be an important relationship between PCSK9 levels, inflammatory cytokines, and the signal to the liver to synthesize CRP. Now, whether this makes a difference in terms of outcomes remains to be determined. The therapy was well tolerated. It's a very busy slide, but just some differences in site reaction, as has also been seen with the human monoclonal antibodies, but these site reactions were short-lived and resolved with time. The Orion 3 study is an open-label extension. Again, the importance is every 6-month administration of the Inclisaran, and in this data trial is still ongoing, so we'll have to wait for those results. But in some of the data that has been presented thus far, we can see that there's a sustained reduction in the LDL cholesterol over time. And when we think about patient adherence to all the medications that they're on, this may be a game changer in terms of prevention. And the idea would be that these individuals would come to the office for their subcutaneous injection every 6 months. So there's a highly consistent profile in these trials: no liver abnormalities, no CK elevations, no renal or effects or thrombocytopenia. Other trials that are ongoing include trials of people with 2 defects in the LDL receptor, homozygous familial hypercholesterolemia, 1 defect, heterozygous familial hypercholesterolemia, and high-risk secondary and primary prevention individuals. And importantly, the Orion 4 study is a cardiovascular outcome study of individuals 55 years of age or older who have atherosclerotic cardiovascular disease, who are being randomized 1-to-1 to placebo or inclisaran. And the primary outcome is clinical cardiovascular events, including urgent coronary revascularization. So this trial is anticipated to be completed in 2024. Whether the FDA will improve inclisaran based on its LDL cholesterol lowering effect before completion of the randomized clinical trial is anybody's guess. So the importance of this approach is consistent and durable efficacy and a good safety profile. Now, what's angiopoietin-like 3 protein? Well, this is a protein where individuals who have loss of function mutations, as I'll show you in a moment, have low levels of LDL cholesterol, low levels of triglycerides, but low levels of HDL cholesterol as well, and lower lifetime risk of myocardial infarction. So let's talk about the genetics, let's talk about lipid and lipoprotein metabolism, and let's discuss some of the early data with evinacumab, a fully human monoclonal antibody directed against this protein. In very important work from Italy, Minicoci, individuals who have one defect in angiopoietin-like 3 protein, we'll call it ANGPTL3, have lower ANGPTL3 levels, and people that are homozygous, of course, have lower levels. What does this mean with regards to lipids? Well, the homozygotes have a 67% lower LDL cholesterol than controls, and heterozygotes have a 9% lower LDL cholesterol level than controls. But there's also lower levels of triglycerides, but lower levels of HDL cholesterol. What does this mean? We could discuss. And lower levels of the atherogenic lipoprotein, or apolipoprotein B. And so the idea would be that with this therapy, you could lower LDL cholesterol, lower triglycerides, but again, what about HDL cholesterol? This is data from the New England Journal of Medicine that looked at loss of function mutations, ANGPTL3, and as compared to non-carriers over here, loss of function mutations, lower levels of triglycerides, lower HDL cholesterol levels slightly, lower levels of LDL cholesterol, similar levels of glucose, and a 40% lower risk of coronary artery disease. So even though the HDL cholesterol goes down, HDL cholesterol, of course, is not in the causal pathway for atherosclerosis. It's really a biomarker of a healthy lifestyle. But with all these changes taken in together, 40% lower risk of coronary heart disease. So ANGPTL3 is an agent that binds or inhibits lipoprotein lipase and endothelial lipase. What is lipoprotein lipase? Lipoprotein lipase is an endothelial localized enzyme that's responsible for hydrolysis of triglyceride-containing lipoproteins. So individuals who are overweight, inactive, who have insulin resistance have low levels of lipoprotein lipase activity, high triglycerides, and lower levels of HDL cholesterol. Individuals who are overweight and people that lose weight can increase the activity of lipoprotein lipase, resulting in lower levels of triglycerides and higher levels of HDL cholesterol. So ANGPTL3 inhibits lipoprotein lipase activity, resulting in increased triglyceride levels. But ANGPTL3 also works on another enzyme, endothelial lipase, which hydrolyzes the phospholipids from the HDL particle and results in higher levels of HDL cholesterol. But if you may be familiar with the very important paper by Voigt in the New England Journal, in the Lancet, that showed that polymorphisms in endothelial lipase were not associated with a higher risk of myocardial infarction. In other words, even though endothelial lipase can affect HDL phospholipids and HDL cholesterol, it's unrelated to the lifetime risk of a myocardial infarction. So we don't think that the changes in HDL cholesterol, HDL phospholipids are going to be important in this situation, but again, that will require a clinical trial to prove that out. What about the clinical data? What's coming down the pipeline? Well, there are phase 1 studies that have been completed phase 2 studies that have also been completed for the homozygous FH patients and other trials that are ongoing, and I'll discuss those briefly. So the phase 1 studies, the first in human studies, gave a single dose and multiple ascending dose administration. This study was just published in Circulation about 6 weeks ago. In the first in human study, they evaluated individuals with triglyceride levels between 150 and 450 milligram per deciliter, and gave subcutaneous followed by an IV administration. Triglyceride levels fell by 23 to 78%. Another study, a cohort had triglycerides greater than 500 milligram per deciliter. They received intravenous evinacumab once monthly, an 80% lowering in triglycerides. In cohort C, with triglyceride levels that are higher, greater than 1,000, averaging 2457, subcutaneous arm followed by IV arm lowered triglycerides by 35 to 63%. So those findings are very striking, and what are the clinical importance is to be determined and ongoing in a trial that we're conducting here at Mount Sinai. What about for cholesterol? Well, there's a study that's been completed in homozygous familial hypercholesterolemia, where again they gave a subcutaneous arm followed by IV, followed by subcutaneous administration, and the reduction in LDL cholesterol is about 50%. All right. And so again, if you are on maximal therapy, you're a very high-risk population. You're not getting to goal on a PCSK9 inhibitor, maybe because you can't tolerate a statin, can't tolerate ezetimibe. You may need something additional, and this therapy would be considered an option when it becomes available and pending the results of some of the other studies. What are the ongoing trials? The study of heterozygous familial hypercholesterolemic patients on maximum tolerated statins, ezetimibe, and a PCSK9 inhibitor who still have elevated LDL cholesterol levels are getting randomized to intravenous evinacumab versus placebo in what's Part B of the study, which is completely enrolled, and then subcutaneous arm, which is ongoing for the same population. And the idea is to move people from the intravenous arm to the subcutaneous arm once the correct dose is identified from this study. Trial of individuals with 2 defects, homozygous familial hypercholesterolemia, has completed enrollment. We're involved in that trial as well, 1629. So let's talk about these ongoing trials in a little bit more detail. The 1522 study is a study of severe hypertriglyceridemia, triglycerides greater than or equal to 500 milligram per deciliter, prior episodes of pancreatitis requiring hospitalization. Individuals have been randomized to intravenous evinacumab versus placebo. We've randomized 8 people into the trial out of the 50 globally, we're waiting for the data to be analyzed and released and look at the episodes of acute pancreatitis, whether triglyceride lowering can affect that. The 1629 study is a homozygous FH study that I mentioned, 57 individuals globally. This study has completed enrollment. We randomized in 3 individuals. The top line of results have been released in a newsletter by Regeneron that it was well tolerated, and on top of maximum tolerated therapy, including PCSK9, a 49% lowering in LDL cholesterol, and we're writing this paper up for publication right now. The 1643 trial in the heterozygous FH patients, 252 individuals. First arm was intravenous, second arm subcutaneous, as I mentioned, and we've been very active in this trial as well as the global lead. So to summarize, human anti-PCSK9 monoclonal antibodies have been a revolution. They've allowed for LDL cholesterol lowering in people that have high LDL cholesterol levels, high cardiovascular risk, despite maximum tolerated statins, with or without ezetimibe. 3 out of 3 clinical trials with monoclonal antibodies demonstrated a reduction in heart attack and stroke, and the Odyssey outcome study, which had enrolled people for a year longer than the other studies, showed an improvement in survival. That's as good as it gets. But we also realize that some of these patients continue to have cardiovascular events, and we may need another therapy. The major obstacles to the human monoclonal antibodies, they're very expensive to make, require a lot of effort, and despite the fact that the costs have been reduced by 60%, the cost of the medication has still been an obstacle for many patients. Even though it may be the same cost as sacubitril valsartan, it may be the same cost as empagliflozin, the initial starting point for these agents, I think, has resulted in a big pushback in terms of its use. But with that being said, for the right patients, you need to get them on this therapy, and we've been very successful, and we help many cardiologists get access to this therapy for their patients. What if you have a genetic disorder? What if you're at very high risk and your LDL cholesterol level is still too high on a PCSK9 inhibitor plus other lipid-lowering therapies? Well, there's another option coming down the pipeline, and hopefully we'll see this monoclonal therapy come to completion and allow for some of these very high-risk people to get this therapy. So thank you very much.